να γίνει για να μπορέσουμε να ξεκινήσουμε στο κανονικό πρόγραμμα. Ομολογώ ότι είμαι ιδιαίτερα συγκινημένος για αυτό το συνέδριο του ΕΛ.Ι.ΚΑΡ, ιστορικό συνέδριο, το πρώτο συνέδριο εις μνήμην Παύλου Τούτουζα, αλλά το 37ο συνέδριο από τότε που ο Παύλος Τούτουζας ξεκίνησε αυτή τη μεγάλη προσπάθεια και πολύ πρωτοπόρο προσπάθεια του Ελληνικού Ιδρύματος Καρδιολογίας, πάντοτε σε συνεργασία με την καρδιολογική κλινική, την καρδιολογική κλινική του Πανεπιστημίου Αθηνών όπως ήταν τότε, εκεί που δίδαξε, αν όχι όλους εμάς, σχεδόν όλους εμάς, τις αρχές της καρδιολογίας και οπωσδήποτε ενέπνευσε πάλι, αν όχι όλους, σχεδόν όλους εμάς, να ακολουθήσουμε την καρδιολογία. Το συνέδριο αυτό του ΕΛ.Ι.ΚΑΡ και το ΕΛ.Ι.ΚΑΡ το ίδιο ήταν κάτι παραπάνω από ένα ακόμη καρδιολογικό συνέδριο. Και αυτό με την έννοια ότι ήταν, θα έλεγε κανείς, ένα πάνελ, πολλές πολυσχηδείς προσπάθειες που είχε κάνει μέσω βιβλίων, περιοδικών εντύπων, άλλοτε εκλαϊκευμένων πλήρως, άλλοτε όχι τόσο ώστε να απευθύνονται σε μη καρδιολόγους, γιατρούς, αλλά βέβαια και στο γενικό πληθυσμό, με γνώμονα ή μάλλον και με αφετηρία το ότι πίστευε ότι η πρόληψη των καρδιακικών παθήσεων δεν είναι έργο μόνο των καρδιολόγων. Πρέπει να περάσουν αυτά τα απλά μηνύματα στην κοινωνία. Τα μηνύματα για το κάπνισμα, για την αντιδραστική πίεση, για το αλάτι και την πίεση και ένα σωρό άλλα τα οποία συζητάμε για πάρα πολλά χρόνια. Ίσως πολύ μεταξύ μας, χωρίς να μπορέσουμε να τα περάσουμε προς τα έξω. Το ΕΛ.Ι.ΚΑΡ ερχόταν να κάνει ακριβώς αυτό και μέσω του συνεδρίου και μέσω των παράπλευρων δραστηριοτήτων κατά τη διάρκεια του χρόνου να περάσει αυτά τα μηνύματα στην κοινωνία περισσότερο. Και επίσης και κάτι παραπάνω, ότι η καρδιά, αυτό ήρθε κάπως αργότερα νομίζω, δεν είμαι σε θέση να πω τώρα σε πιο ακριβό συνέδριο του ΕΛ.Ι.ΚΑΡ, αλλά κάπως αργότερα, ότι η καρδιά δεν ήταν μόνη της, ότι τα αγκία δεν ήταν μόνα τους, οι καρδιακές παθήσεις δεν ήταν μόνες τους, αφορούσαν όλο το σώμα, αφορούσαν και τον εγκέφαλο. Προλαμβάνοντας καρδιακές παθήσεις, προλαμβάναμε ή θα μπορούσαμε να προλαμβάνουμε και την άνοια και ότι η ψυχική ευεξία προλαμβάνει κατά κάποιο τρόπο καρδιακές παθήσεις. Αυτά τότε ήταν πολύ πρωτοπόρα. Την τελευταία 5-10 χρόνια έχουν αναπτυχθεί σε πάρα πολλά ιατρικά κέντρα σε όλο τον κόσμο και στο δικό μας, στη Νέα Υόρκη, παρόμοια προγράμματα. Αλλά μιλάμε τώρα για προγράμματα τα οποία είχε εμπνευστεί ο καθηγητής Παύλος Τούτουζας προς 40 ετίας τουλάχιστον. Καταλαβαίνετε λοιπόν από αυτό το πρίσμα πόσο συγκινητικό είναι να βρίσκομαι και πάλι σήμερα σε αυτό το συνέδριο, το οποίο παραδοσιακά γίνεται την εβδομάδα της διακαινησίμου μετά το Πάσχα, και να έχω και τη μεγάλη τιμή να προλογίσω αυτή την ιδιαίτερη τελετή, θα λέει κανείς τη λήξωση, όπως θέλετε να το πείτε, το ακροτελεύτια συνεδρία, και θα αλλάξω τη γλώσσα στα αγγλικά τώρα για να προλογίσω τον καθηγητή Τούτουζα, τον καθηγητή Fuster, ο οποίος είναι και ο πρώτος, θα είναι και ο πρώτος διακεκριμένος ομιλητής εις μνήμην Παύλου Τούτουζα. It's my great pleasure to introduce Professor Valentin Fuster, a famous cardiologist worldwide, and a friend and collaborator of Pavlos Toutouza's as the first Pavlos Toutouza's Memorial Lecturer at this conference of the ΕΛ.Ι.ΚΑΡ Hellenic Cardiology Foundation. Professor Fuster is directing the Mount Sinai Heart Cardiovascular Institute for several decades. However, also has founded and directing the Center of Cardiovascular Research in Madrid, a very large, a huge center there, national center, pretty much like the Academy of Athens Center here, but much larger. At the same time, he has won repeatedly many awards. The latest is the the very much revered Prince Mahidol medal and award. He's a gold medalist of the European Society of Cardiology. He's a past president of the American Heart Association and an awardee, a major awardee repeatedly of both the American Heart Association and the American College of Cardiology. And more importantly, through his research and his passion really for cardiovascular prevention, merge this with cardiovascular imaging. And again, along the lines I was previously explaining to you, he also believes that the heart is not alone. The cardiovascular system is not alone. They affect the brain affects them, and the well-being of the cardiovascular system is the same as, or very similar to well-being in the brain. The cardiovascular disease and prevention of disease is not the same as promoting cardiovascular health, and that promoting cardiovascular health is another very important goal we have to have. And imaging is very, very important in order even non-cardiologists or even lay people react to imaging much more regarding compliance, understanding of what we tell them, and ultimately cooperating with the advice they get. So the lecture of today, the title is exactly this: how imaging and how cardiovascular health is intertwined with the global health, the total health of the body, I should say, and with neurologic health and prevention. Professor Fuster, I hope you are listening to us and you're very well connected. You can get started anytime, and many thanks for joining us in this 37th Congress of the Hellenic Cardiology Foundation as a first Pavlos Tούtuzas Memorial Lecturer.
Well, thank you very much, George. Can you hear me well?
Excellent, excellent. Can hear you crystal clear.
Thank you. I appreciate very much this invitation as the first Pavlos Tūtuzas lecturer. I remember him quite well, actually. He had so much impact, not only on Hellenic cardiology, but this transcended internationally. And certainly I feel very proud to be the first lecturer on his name. Actually, I have a title which is Development of an Innovation in Cardiovascular Health. And then in the bottom, you have age-dependent program. That is, if we talk about health, which now we know less than about disease, and we have to understand health, what makes somebody healthy, this is quite different in different ages. And in order to address the issue of health, we need new technology. So this is the basis of my presentation today. And I'm going to actually focus, as you mentioned, on imaging and genomics, presenting to you 5 different new concepts that evolved in the last 3 years, and we participated in the development of such concepts. These are how the 3 titles I mentioned are now summarized in an image. We have been working for a long time on the disease #1 killer, which is atherosclerotic disease. In particular, we have been working on people who already had cardiovascular events. The movement now is to understand how this develops much earlier when there is no manifestations of the disease clinically. Second, it is important that we now realize that if we go earlier, we have to deal with different ages. How are these arteries at age 100 or age 60 to 100 on somebody who has not developed clinical disease? What about age 20 to 60? And what about from birth to age 20? These are very important challenges to really understand health at these 3 different ages. And here's the technology. We talked today about imaging and genomics, artificial intelligence. We can have a circulating cell like a macrophage, a monocyte that combines many aspects of each of us individually. and then finally therapies, new therapies, which basically are based on understanding how health pathways defend of ourselves and how can we enhance these defensive pathways that we have during health. This is the basis of my presentation today, and I'm going to go now into what is important, is that is this aspect with imaging and genomics in the context of health. Here, let me start with concept number one, risk factors. As we know, we have 7 risk factors that are important. 2 are mechanical, obesity and high blood pressure. 2 are chemical, here's the pancreas, diabetes and high cholesterol. And 3 are behavioral, I would say, tobacco, cigarette smoking, a poor diet, not necessarily leading to obesity, and lack of exercise. And let's not talk about genetics at this moment. We have to, in order to understand how these risk factors affect or impact on an artery that is still normal, we cannot go into intravascular imaging, which we do it particularly when there is already disease, and only very few people, really we can get into that aspect, and I'm much more interested in global health. Can we go with technologies that are not too expensive, and can we address who is developing the disease, who is not? And actually, the concept that we began to work with was in people with an intermediate age. Actually, between age 40 and 55, we have 4,000 people, but we have also data between age 20 and 40, which I will be presenting. We develop imaging technology that can be affordable. This is 2D and 3D ultrasound, by which we can look at the different arteries of the body, particularly 5 regions. 2 carotid regions, the 2 carotid arteries, the iliofemoral arteries, and the main aorta. And then we can do CT to address coronary arteries in terms of extension of disease, I would say indirectly. The first thing that we learn by doing this kind of technology is the disease begins in most of the people in the iliofemoral region. Clinically is not manifested because these are large arteries, and only the small arteries manifest disease, like the coronary arteries. But that's where the disease begins in about 75% of the 4,000 people that we image between age 40 and age 55. Interestingly, if we look at age 45 to 49 males, 2/3 already had disease in one of the 6 regions that I mentioned. This is one region, 2 or 3, 4, 5 or 6, 2/3 of males, half of women at this age. Later on, women, the disease accelerates. So we are really facing a situation of subclinical disease that starts at young age. We knew this by autopsy, but not by imaging. And this is between age 40 and age 55. But most importantly, we are following these people for 20 years, and at 4 years of follow-up, 41% already have some of the plaques that actually progress. So we are dealing with a real issue when in fact we feel that we are feeling fantastically well and we don't have any problems, and the disease is developing in a significant number of people without realizing it. This is actually interesting because what you see here, I like to show you this slide first, and that is we did positron emission tomography and MR, magnetic resonance imaging, to assess the arteries in 900 of these 4,000 people. And here what you have is positron emission tomography showing the inflammatory process and the cholesterol. When cholesterol is there, the bone marrow reacts and sends cells there to take care of the cholesterol and to absorb it. And this is a fantastic role of the bone marrow. And at the beginning is a winner in the war between the bone marrow that defends ourselves and the cholesterol that is a foreign body. The bone marrow wins. And these lesions that appear to be fatty lesions and with inflammation end up by magnetic resonance imaging in fibrotic lesions. All is great. Now the problem is if more cholesterol or foreign body enters into the artery, the bone marrow reacts. But at one moment, it decides to commit suicide, these monocytes, because they feel there is too much lipid material in the vessel wall during people who have not been taking care of their risk factor profile. And when these cells commit suicide, called apoptosis, they release cytokines, metalloproteinases that may lead to plaque rupture, and tissue factor that may lead to clots. So basically, when we talk about acute coronary syndromes, what we are really dealing is with a significant substrate of lipid material that enter into the wall by the damage caused by all the risk factors, and by entering the wall, if the risk factors are not controlled and the lipid material is overexposed and there is too much substrate, then the acute syndromes evolve. The bone marrow has failed and has committed suicide, the cells that are sent out. So here we have defense mechanisms. Number one is very good. There is not enough foreign material and the monocytes win. Number two is the apoptotic phenomena. There are too much substrate and the bone marrow loses. And then the inflammatory process and the suicidal thing releases all these substances that are actually very damaged. Well, this is the data. We published this week, actually, in which you can see the bone marrow, how it reacts with positron emission tomography. This is in blue. And how this is what happens in the artery. The cells go there. This is in humans, in these people I am mentioning. And this is actually the fight that is taking place between the monocytes and the deposition of cholesterol. So the first concept that I wanted to really comment here is that cardiovascular disease, and particularly atherothrombotic disease, begins early in life. Unfortunately, is silent. The iliofemoral region is where it starts in a large number of people, and the risk factors and the inflammatory process as a defense mechanism are the protagonists of what goes on in the arterial wall. Well, this being said, let me now go into the second concept. We have in these 4,000 people, there is one group that is high risk according to Framingham, others middle risk, and others low risk. How is possible that having a single risk factor out of the 7 or none, still we see disease? How is possible that we see patients without obvious risk factors and they present with acute coronary syndromes or strokes? Well, anybody thinks, well, is Lp(a) elevated? CRP is very elevated. This is fine, but I'm going to present to you two aspects that we have found in this study, which I'm sure you are going to find very interesting in trying to answer this question. First, when we look at LDL cholesterol, in the guidelines, normal LDL cholesterol is between 100 and 120 if you never had a heart attack or a stroke. But when we look with imaging subclinical disease, look what happened. When you actually look at all the other risk factors and you establish just LDL as the only one, you need an LDL of less than 70 milligrams DL to actually not to have subclinical disease. So what we call normal is actually quite abnormal if we look at subclinical disease with the new technologies of imaging. The same we found with hemoglobin A1C. The pre-diabetic patient with a hemoglobin A1C between 5.5 and 6, we say this is an alarm. Is pre-diabetic, one day may develop diabetes, and this will be a problem. No, my friends, the problem is already with the pre-diabetic stage. We found the same thing. A hemoglobin A1C of 5.5, there's a lot of subclinical disease already. And so with triglycerides, more that are about 155, 160 is too much. So what I'm really trying to convey to you that one of the reasons why we say why it happened when in fact there were no risk factors is because we don't know what the normal risk factors are. All these guidelines are from age 40 on and based on events that take place, but it's not on subclinical disease that we find with this imaging technology. But let me tell you more about it. And now comes the second observation. We decided to look at what happens between age 20 and age 40. And we went into the cardiac study. They have a very long follow-up. And the surprises are tremendous. What we did is we look at the effect of LDL first and other risk factors. I only show LDL now, and see what happened, the effect of LDL between age 20 to 40. What is this effect in cardiovascular mortality at a long term in the cardiac study? In the cardiac study, and what we found is this. At age 40, it is looking at all these people that already had imaging technology, and what we see is the higher is the accumulation of LDL between age 20 and 40, higher is the number of cardiovascular events. And this is what you see. So it is interesting that we are ignoring in the guidelines what goes on between age 20 and 40, when in fact is critical of the events that take place later on. So what I'm presenting to you is the following concept. Cardiovascular disease is frequent without obvious risk factors and it starts at early age. But we have a problem. The risk factor level. We consider normal what is abnormal. And also we don't take into account the cumulative effect of the risk factors at earlier age. These to me are two important aspects that actually make silent disease very important to be considered in younger age, because have a huge impact into what happens earlier. And I'm presenting to you real data, and I'm presenting to you the references and the papers that are coming out at this moment on these two concepts. So we decided to get into the third issue, and that is, if everything starts at young age, and actually what we consider normal is abnormal, let's do the following study. And this is the first trial that I know that is going to approach the issue at young age. Patients or individuals, not patients, between age 20 to 40, if they have an LDL higher than 70, are going to be randomized into a very active treatment in dropping this LDL to 50, 40, 30, 60, but certainly much less than 70. Compare with a control group, and we will follow guidelines. The guideline says take care of the risk factors. They don't say they don't have any endpoints. And this is what is very important to realize. The guidelines are based on people from 40 years of age on, and when there are events taking place. But there is nothing, really nothing, that it tells us the tremendous impact of what happens at younger ages. This trial is going to approach these. Endpoints are young people. So you follow progression of the disease at 10 years. This is what we are going to do, start at 5 years and 10 years. But you say, you know, progression of disease, I am skeptical. This has nothing to do with the development of events. Well, just a second. The development of events will be a secondary endpoint, but I have more to say about it. This is the study that you are going to be seeing published very soon, and it's fascinating. Here we have 6,000 people that we use the same technology between age 60 and 100. Here there are events, and what we found is higher is the burden of disease subclinically at time 0, higher is the number of events, in this case mortality, afterwards. So what we are really saying to you is that once we look at progression of disease at later age when there are events, there is no question that the burden of subclinical disease at time 0 in these later ages actually it tells you what would be the mortality. So in a way, in our study, pre-cut are young people, but when we see a burden of disease, we will statistically look at what if this burden of disease was at age 60? What would be the number of events or the impact or the incidence of events? So the secondary endpoint, not necessarily we are looking at an event that happens at young age, but we will project the progression of the disease that we learn about events in later age. So this is what we are going to do. So here the concept is that we are going to have a unique trial or an approach considering an LDL abnormal if it is more than 70 milligrams DL. And then from that point, we are going to do the randomization and the 5 and 10 year of follow-up. Again, we are very excited about this new approach in really getting into younger age. And now comes the issue. This is all fine, but many of you sitting there says, well, this is academically very interesting, but I'm going to see a patient tomorrow, and I'm not going to know what to do. Well, let me tell you, we have looked already at 6 studies with 2 therapeutic approaches in patients who already have, or individuals who are completely healthy, but they have subclinical disease. One was the individual approach. For example, in Kenya, they have high blood pressure in the region that we work because they keep the food with salt. They don't have freezers, and they develop hypertension. I will tell you, you can always work individually in a hypertensive people in trying to send them guidelines and phone calls and pamphlets. Very nice, very expensive. I can tell you the individual approach to risk factor profile, you can make it in your office and it's fine. But if you go to the population in general, very difficult and extremely expensive. So we took a second approach, which is the approach of group therapy. And we did this in the island of Grenada. We did this in Cardona, is a town of Spain, and then in 7 institutions of Spain. And this basically consists in you get 10, 15 people. One is obese, the other is the high blood pressure has not been controlled, the other has a problem with the smoking, and they help each other. And they have a tutor who also have all these weaknesses. You cannot have a tutor that is perfect. It doesn't work in our studies. You have to be weak, to be people that will follow you. Very interesting paradox. And then what they do, they meet every month. Through peer pressure, I guess, they help each other. The results were exactly the same, the individual approach and the group therapy approach, with a great difference, the cost. Individual approach is very expensive. In the group approach, all these studies, by the way, are randomized studies. But let me give you a little bit of the overall results of our studies, and are presented here. You start with the individual or the group therapy, and it's fantastic intervention. But what happened? After 12 months, you are not so successful. You may come down, you may certainly gain from the baseline, but this is point number 1. In point number 2, look the controls, why they do so well. And now we are understanding culture. Whenever you are doing something to your neighbor that is intervened, you are going to look at and you will begin to think, maybe I should do something about my health. And this is actually what happens, the tremendous influence of culture. In any intervention study that we have done, the family members or the people with where the intervention was done, they behave better. But the data is not sustainable. So what we are now learning that in fact, what you need is another intervention every 2, 3, 4 years, and then the results are exponential. In other words, we are now on a hypothesis that is very interesting, and that is we as humans are not sustainable, certainly on health and in many other things, I would say. You need to reintervene constantly. And in this case, every 2, 3, or 4 years. So to me, a challenge of health today is first should be not expensive. And we are talking about group therapy on one hand, and on the other hand, it should be sustainable, and that it should be reintervened, and the results appear to be better and better. And this is actually the concept number 4 that I'm presenting to you here. And that is modification of risk factors are transient, and their re-education is important. We have to keep this in mind. Otherwise, we are frustrated. There's nothing more frustrating that somebody goes to a dietitian and now weight loss and you lose 20 pounds. The dietitian doesn't call you anymore. It's all yourself. And 1 year later, you are back to the same weight than before. Please be sure we are conscious of the importance of the sustainability. And this goes for the dietitian, it's just an example, as it goes to the patient. And now this leads to the next question, which is genetics. And this is very fascinating. The question is, what is most important? the acquired 7 risk factors we mentioned, or the genetics? We did the study. We published this in 2016, actually, and this was the combination of the ARIC trial, the trial in Malmo in Sweden, our study, the bioimage. These are the patients between age 60 and 100, the 6,000 patients I mentioned, and this is the women's health study carried out in Boston. And what we did is we did a risk factor of genetics. We took 50 genes that were recognized at that time as being important in coronary artery disease. And we look at the number of mutations. And depending if the number is a high risk, this is no mutations, low risk. And we found this was a significant relationship, genetically speaking, between the risk that we took by the number of mutations of these 50 genes with the number of events or progression of disease, in our case. And then we did the same thing with the risk factor profile. If you have 4 or 5 or 6 risk factors, you are a high risk. If you have only 1 risk factor or so or less, you are in a low risk. Well, these are the findings. First, interestingly, they are both independent, and that is no relationship except in diabetes type 1 and in familial hypercholesterolemia. So you have 2 variables that may affect us. But what we found, number 2, if most of the individuals with a high genetic risk had acquired risk factors. In fact, in the population in the United States, about 96% of people have one of the 7 risk factors I mentioned. 4% have none. I'm talking about the adult population. So if you take care of the risk factors, you have a high risk factor in terms of genetics. But you have hypercholesterolemia and you use your statins and you drop the risk factor, you have a 50% reduction of the number of events. I'm talking in this case in people in which the risk factor was high cholesterol. So there is no excuse to say, I have a genetic risk and this is a problem that I cannot solve. There's another issue about genetics that is interesting, and that is we say terrible family history, terrible family history. We found that in a large number of people, the father was a smoker and you are a smoker. The mother had high blood pressure, you have high blood pressure. So not necessarily family history means you have a terrible genetics. And this is something we learned with this study. But there is something else that is most important. What these genes do. When we tell these genes are mutated, what this has to do with coronary artery disease, we know in hypercholesterolemia, and we know certainly in diabetes type 1, but in general. And this brings the concept of CHIP. What is CHIP? The hematologists know very well, so-called clonal hematopoiesis of indeterminate potential. And this is basically the cells from the bone marrow that go to defend you. Those cells may be altered genetically. That's why the single cell that circulates has so much power when we try to understand ourselves. And these mutations are carried by the cell that is supposed to defend you. But this is a problem. If you have this mutation, this defense doesn't occur. It's like the motor engine is not working. And this is actually what we call CHIP. And one of these genes that we found quite interesting is TET2. Let me tell you what happened. Whenever there is, for example, a foreign body, cholesterol, there are macrophages that in the past we called macrophages type 2, that they create a fibrotic phenomena here that we see with MRI. The fatty streak is converted in a fibrotic lesion. Beautiful. But if a plaque is complex and there is thrombus and cholesterol and so forth, what happens is that there is a defense mechanism from the bone marrow. You know, these macrophages type 1. And you know who calls them? Interleukin-1. Interleukin-1 is like a police saying, there is trouble in this artery, please, bone marrow reacts. Interleukin-1, and what happens is, in general, this defense is so aggressive that the whole thing gets destroyed, even worse. This is why in the CANTOS study, by neutralizing interleukin-1, I believe in patients who had previous, actually acute events, the issue is that you prevent this defense mechanism to be so aggressive. And this is what TET2 is doing. And if TET2 is mutated, bad news. So now the question is, the CANTOS study with neutralizing monoclonal antibodies interleukin-1 is actually interleukin-1 may be as bad as is a mutated TT2. And the question is whether in the future, editorializing these genetics, we can make TT2 normal. But I'm just giving you the sense, very, very important sense. And that is, it is in this, actually, in this slide that you see here, is of all the defense mechanisms that we have, the first one, the early fibrosis, excellent. The second one, apoptotic phenomena, bad news. And the third one is not that you have a lot of substrate in the cell and the monocyte actually commits suicide, apoptotic, releasing all the substances, but the motor engine is not working, bad risk factor. And this is probably the key of the genetics in coronary and atherosclerotic disease in a number of entities, and particularly in advanced age. But now comes the great surprise. And again, this was published this week. And the great surprise is in everything I'm talking to you about the bone marrow. Now look at this one. We found that obesity, hypertension, diabetes as part of the metabolic syndrome stimulate the bone marrow by themselves. And the question is teleologically, how do you put this together? On one hand, these risk factors damage the artery and make cholesterol to enter into the vessel wall. At the same time, they are calling the bone marrow. And here's the question. We don't know the answer. Is this calling the bone marrow to say, you know, I have committed some damage in the artery, but please come and help? Or is by overstimulating the bone marrow, we create a hyperinflammatory process that makes the individual worse? We don't have any idea about this, but this is a slide of the actually of the comment made by my friends on the paper that we just published this last week, and that is bone marrow, mischief in the marrow, a root of cardiovascular evil, can be good and can be bad. Look, it's good, no question, in the fatty streak or in the cholesterol that may handle. Then comes the apoptotic phenomena. Number 2, defense mechanism, bad news. Number 3, the genetics don't work. Number 4, the risk factors stimulate the bone marrow. Is this good or is this bad? We call green good news, red bad news, yellow we don't know. Well, this is the story. When we talk about cardiovascular events, we are talking about a defense mechanism that is betraying you. Apoptotic macrophages, or maybe the motor engine is not working, the mutations, and we don't know about the risk factors stimulating the bone marrow. So I would say that when we talk between age 20 and age 60, the key question is, do I have disease or I do not? And imaging and genetics may be important. And now we are beginning to move into developing countries, and the device that will be public very soon will be automatic, how you measure the amount of disease in the arteries by cubic millimeters. Going to the legs may be sufficient and very cheap. And looking if the disease is there, you can predict it's going to extend. This is a systemic disease. The question now is, what is the challenge between age 60 and 100? The challenge is your brain. And that is cognitive dysfunction. It's not how many years I live, I believe, it's the quality of life. And here the project that we have is called TANSNIM. It's a transatlantic project between New York and Madrid. And basically here we have individuals that on one hand, they have large arteries being affected. You see the carotid arteries and so forth. And we do imaging of all these arteries, but we go also to the brain. We go to the brain, we do neurocognitive testing, positive emission tomography for amyloid and Alzheimer's, and we measure the flow in the brain of the blood. Why? Because we have a hypothesis that the same risk factors also affect the microvascular of the brain. And we are finding this through new technology. And here's the other side of the coin. We have people with neurocognitive disease, and then we go to the large arteries and we look at the carotid arteries, we look at the risk factor profile, we look at the iliofemoral region, and then we also look at imaging of the brain. Here we start with cognitive function. It's like a crossover study. Let me give you what we are learning. And I don't have much time to go into the details. First, the risk factors affect the large vessels, and this may lead to mortality. We know this, and this was the first part of my presentation. Second, the risk factors affect the microvascular of the brain. In fact, with magnetic resonance imaging, we found a decrease in the flow of the brain in hypertensive people, in hypercholesterolemic people, and in people with diabetes. Decreased flow of the brain. Most importantly, with PET, we found a decreased uptake of glucose. We just published this in the brain in such situations with high risk factors, and so cognitive dysfunction. But even more, this process that takes place in the large arteries and affects also the arteries of the brain that now we are learning with all this new imaging technology may accelerate a disease, the Alzheimer's disease. And it's interesting that Alzheimer's 100 years ago, 120 years ago, said, my disease is vascular. Nobody pay attention to this. Since it's cognitive dysfunction, everybody got into the cell. And certainly the disease is important in the cells of the brain, but we are now beginning to learn that the microvascular is critical in accelerating this disease. But even more, and again, this is published, and I can talk about this in more detail in another occasion, microthrombi are formed by the beta amyloid. And that is the same amyloid that enters into the brain is procoagulant in the tiny vessels. And this may also accelerate Alzheimer's. So in fact, talking about the brain, and I am summarizing, the cardiovascular risk factors that lead to heart attacks and strokes may actually affect the vasculature of the brain, hypoperfusion, lack of entry of glucose into the brain, cognitive decline, senile dementia. And in Alzheimer's, it may be the same pathway, but it may be another, which is the clots that take place in the microvasculature by the beta amyloid. And here obviously can affect also the cells of Alzheimer's by the nutrition and also contribute to the cognitive dysfunction. The problem with this study is that not the same individuals had all the technologies. And this led to the study that we started a year ago. The same individuals are going to have all these phases of going longitudinally in looking at all these technologies to see how disease develops and progresses in the brain. And I will tell you something we have learned. First, we talk about troponins in patients with ischemia. We now have biomarkers telling you when the brain begins to be affected by some of the issues that I'm present. This is very, very new. And the other thing that is very practical, when a patient comes to us and says, doctor, I am tired, you tell me to stop smoking, to lose weight, you're making my life miserable. I prefer to die suddenly and nobody will bother me. Well, I tell these patients, I am not sure with the rehab, with the rehabilitation, with the programs that we have now on emergency basis, you might die suddenly, but you might be resuscitated in 5 minutes. But most importantly, you don't want to be that we alarm you by you controlling all the risk factors. What about your brain? What about if you cannot even see or know who is your brother, your sister, your mother, your son? You don't remember the names. What this will affect you? And they react rapidly. So one thing we have learned with all these studies that address the brain is the society today is more sensitized about cognitive dysfunction than heart attacks. So when you have your patients, cardiology patients, that they don't want to hear from you what you are advising them, talk about the brain, and you will see how they change. This is something we are learning. And now I finish. And I finish with what is most important, but I am going to spend only 1 minute, and that is children. We have the challenge between age 20 and 60. The challenge at this age, do I have disease or do I not? And I already talked about imaging and genomics. 60 to 100. Actually, the disease begins very early, but ends up with cognitive dysfunction. What about at this age? Well, basically, what the project that we have, actually 50,000 children around the world, we have randomized studies, and the concept that we are developing with the Sesame Street, maybe it's an educational program that you remember when you were younger or your children. At age 3 to 6, the number of centers of the brain is very small. So what happens is anything you tell to a child, they capture it. It comes out later on in adult life. Remember the environment that you have between age 3 and 6. has a lot to do with how you are today. And what happened later on, more centers, and in adults, we don't listen. It's too complex, and it's all very unstable. So the concept that we develop is, can we teach these children health? And we are doing this over a 60-hour period, over 6 months in the preschool system. And then we follow these children, thinking that when they are adults, they are going to have much more sensitivity to the importance of health because they learn this at that particular age. We have a lot of data, actually, when we are dealing with 50,000 children. All are randomized studies. I just finished by saying to you that I am absolutely convinced. We all have been working when the disease is late, very costly, and the benefit not great. We have to move earlier and earlier. The potential benefit is huge, and the cost is much less. So I just finishing by saying to you that I presented to you 5 concepts of middle age that are very important and new, and are related to new modalities of imaging and genetics that are telling us a lot of things. I got briefly into the brain to tell you that our program is different when we are dealing with the elderly population, but with the same technology, however, we are learning a lot. And then I just mentioned by passing that one of the main programs that we have are actually in children, because we are very strongly believe that that's the age, is the gold age for the future in terms of talking about health. Anyway, I finish here. Thank you very much for giving me this opportunity, and certainly for giving me a lecture related to an individual that has had so much influence, not only in Greece, but in the rest of the world, Dr. Tútuzas. Thank you very much.
Thank you, Dr. Fuster, for this tremendously stimulating, tremendously academic, and tremendously, I would say, detailed approach of the cardiovascular system and the implications, not only for heart, but also for blood vessels of any organ, including, most importantly, the brain. And very interesting, of course, you see so many patients in many parts of the world and from many parts of the world every day. That's why the example you chose, it's one that is discussed many times by many Greek patients here in Greece. That why you bother me with all these various modifications? Let me go, and one day don't worry, I will not just sleep the next morning and I'm fine with it. And you went to the essence of it on how erroneous this is and how a wrong approach this is. And, definitely spoke to the heart of many of the doctors here who are dealing with patients day in and day out as well. I received several questions via the feed. And an obvious one, I think you relayed a little bit to it, but let me ask it as people wanted to know. The many preventive measures of pharmacology, the statins, daily pill, the PCSK inhibitors, a monthly injection, or maybe an injection once a year or every 6 months or something lately. Could it be another anti-inflammatory injection against CRP or something else? Could it be something against the lipoprotein A that is coming up in trials? Could any of those be of any help in early stages and in younger ages? What do you think about that possibility? I know you relate to it, but please, make a short comment again, because it came up in several questions at the feed.
Well, first of all, young age is the key, and this is why we try to modify the young age pharmacologically. You have to know that we are going to start with red rice, and then moving into statins, it becomes necessary to drop the LDL cholesterol. But I think talking about pharmacology, to me, the pharmacology of the future will have 2 aspects. One is how can we enhance our defense mechanisms? And you have examples. The cardiac failure, the new drugs are all enhancing defense mechanisms that we didn't know how they operated before. the mRNA for the vaccines. We thought the mRNA is a result of disease in certain organs. Now it's a defense mechanism. So that's how the vaccines from Pfizer and Moderna evolved. And so it's going to be the future pharmacologically that will be based into what we are learning now as defense mechanisms of health. Can we enhance them? And then there's a second issue pharmacologically. There is no question. The issue of adherence is extremely difficult, and you will learn from us very soon about the polypill study. The issue of adherence is very important. So I think in the future, we have pharmacological tools that will be injected subcutaneously, I suspect, once every 6 months, once a year. So where I see the future of pharmacology is in two areas: understanding the defense mechanisms in the period I am discussing, that is health, and trying to enhance them. And second, to be over the issue of adherence by giving these pharmacological agents with a long-term type of injection. This is the way I see in 10, 15, 20 years how we'll be operating pharmacologically. But young age is the critical age to start.
Yes, well, definitely to the point. Another subject that came up is you focus a lot on silent disease, what we call a subclinical disease, or one may call it a random finding. Like someone has an ultrasound for whatever reason, and all of a sudden they found plaque. And you put a lot of emphasis on how important this is and how deleterious this may be a decade or two from that point. And many may, I think in the daily practice may just dismiss it. Oh, you did that for at random, no real indication, forget about it. And at the same time, and how is this, we're inundated by different societies' messages about the inappropriateness, perhaps, of aspirin prevention therapy in patients who don't have confirmed disease or something. Would you consider the silent findings of ultrasound-positive atherosclerosis an indication for aspirin, or what is happening with all these aspects to withdraw aspirin prevention from populations that may have silent atherosclerosis? Based on what you tell us, what you heard, perhaps we should exert more preventive measures based on what we read on many societies, and every patient is texting and calling. They want to stop it even. What do you think about that, and how is this affected, perhaps?
I have 3 comments. Comment number 1, the guidelines are quite old and primitive. They don't take into account young people. I think this is very important. They don't take into account subclinical disease. They don't. So that's something that has to change as we have these imaging technologies showing how subclinical disease is important. Number 2, to find it is coming in the near future. You will have a device, you will look at the risk factors, and you will put the device in the iliofemoral region. And then comes the question, what I do? The first thing you should do is what we are presenting here. We did this in 4,000 people, and actually also in a study in Harlem. And that is, can we, in a way, control the risk factors that I have rather than taking 1 aspirin a day? It's very easy to take an aspirin a day, but my friends, the problem is more than that. And that is, those technologies, it will tell you that something is wrong with your risk factor profile. Many times, numbers that you thought were normal and actually are not normal, like an LDL of 90, for example. So I would say to you that beginning to take aspirin today because you see something in the carotid artery, I would be much more deeper than taking aspirin and trying to find myself whether something is wrong that led to that plaque. I don't think aspirin is the answer, my friend George. I don't think it's the answer. The answer is go much deeper, is why I have this plaque.
So we should not dismiss random findings, despite or regardless of what we do about aspirin, which may be a minor issue. The major issue is to keep screening the patients and following them. A final comment.
Risk factors in the future will be risk factors in using a device. Today, if you find by random you have carotid disease, you are very lucky. You have the time to change behavior.
Excellent. And staying with risk factors, I want to underline, and the last question it will be this one. What you said regarding genetics and how to distinguish with what happens in the family as far as training or bad habits, really, regarding a salty diet, smoking, and perhaps even bringing up a new issue that we have emerging, vaping. In my mind, worse than smoking. And we unregulated, unstudied, and unfortunately, very prevalent. Perhaps you can offer us few comments about that and how important it is to distinguish a genetic factor, a genetic risk, a true genetic risk, from just what repeating whatever the young kids see, whatever the family does. And at the same time, how important it is that the young kids, if they're taught something at the schools, they spread the word in the family and, in essence, teach their parents or at least motivate their parents.
Look, I didn't talk about children, but the children have more influence in the health of the parents than the parents in the health of the children in our programs. The problem here is that you have to create a culture in the family. And to create a culture in the family, we have a new program that we get into the family. And I don't have time to present it today, but it's fascinating, which everybody gets involved. And having said this, I think that is very important, and this is what we are finding. When we talk about genetics, we have to distinguish between poor habits in the family from genetics by themselves. And we find this now that all the patients come to me that before I thought, well, heart attack, my brother at age 40, all of these I thought before were all genetics. Now, after we did the study, we learned that not every time is there. In 50% of the times, actually, if I have to give you a number, is something that is acquired and is culture of the family and so forth. So I think I would give very important about the electronic smoking. And I will tell you, I think it's going to be a problem. And I can only talk to you for everything I'm learning slowly. So at this time, everything is going on like everything is fine. But the fact of the matter, people get involved with this. They are not able to stop it and say, you use excuses. I'm going to stop smoking because I'm doing now this different way. I think this is going to be a problem in the future, but I don't have the data to actually to say more than that. I think it's not going to prevail as a non-risk factor. It's going to prevail as a risk factor. This is my view, and it's a very personal one.
Noted, noted and great. Καμία ερώτηση από την αίθουσα? Oh, you know what Dr. Fuster looks like? We're talking for just a few minutes. I look at my watch here. It's been an hour. And I can tell you that I know another, and many people here knew another professor of cardiology who used to captivate the audience regarding all sorts of things, even outside cardiology. And that was Pavlos Tūtuzas. So no wonder. Yet again, you were selected to be the first Pavlos Tūtuzas lecturer in his own foundation, the Hellenic Cardiology Foundation, and on behalf of the organizers and the vice president of the foundation, Kostas Tūtuzas also, who is here, obviously, and all others who participate live and via the many more via the internet. I'd like to congratulate you as well as thank you for this outstanding presentation. Thank you, Dr. Fuster.
Thank you all. Thank you very much. Thank you. Thank you.
Κώστα, να κηρύξουμε τη λήξη της ημέρας τότε και ευχαριστούμε όλους για την παρακολούθηση σας εδώ.